And hello everybody, and welcome to Facebook Friday. It is Friday the 4th of June 2021, and I am Kate Wakelin from Neuroendocrine Cancer Australia. Each week we broadcast into our private Facebook discussion group and address a topic of the week in relation to neuroendocrine cancer. So it's really lovely to have you join us today, and you will notice that I've got some very special guests along for the ride today, and I will be introducing them a little bit more in a moment. But before we go on, I just want to take this opportunity to acknowledge the traditional owners of the land that I am sitting on, which is the land of the Wurundjeri people of the Kulin Nation, and just like to pay my respects to elders past, present and emerging. Actually, this week is Reconciliation Week, so it's really important that more than ever that we take this moment just to pause and reflect on that. One thing that I do in on the land that I live on is I do lots of running along the Yarra River, which in the Woiwurrung language is called the Birrarung. So I'm very grateful for where I am, and especially at the moment because I'm in Melbourne and we're in lockdown again, and I'm very lucky that that river is within my 5K zone. So if you are watching from Melbourne, shouts out to all of you. We know that it's full on and tricky, and both of our experts are also joining us from lockdown Melbourne, so thank you and commiserations. Just before we go any further, I also just wanted to do my usual disclaimer that the information we're talking about today is obviously not personalised, and so it's just general in nature only. And so for your own situation, please do talk with your doctor and your treatment team, because we know that that NETs are very, very diverse, and so what we present today may not be relevant to your situation. So always take things that we hear on here with a big grain of salt and take them back to your treatment team to discuss anything that you have questions about or that you want to explore further. So without further ado, I would love to introduce Dr Sharyn Stock-Myer and Dr Fleur. And it's Cattrall, isn't it? Fleur, not
It
Cattrall?
is. Thank you. Yes.
Fantastic. And you are both from, and look, my notes have just disappeared from my screen. So you'll have to, maybe I'll let you introduce yourselves. And we're talking today about fertility and NETs, including managing fertility for people who are having cancer treatments. So things like chemotherapy and radiotherapy and those sorts of treatments, but also knowing that there are a percentage of people with NETs who carry a familial genetic predisposition, and we've got an expert with us today who is talking about that preimplantation genetic detection process. So I'm really looking forward to learning lots about that process today. So, but maybe Sharyn and Fleur, thank you so much for joining us. Would you mind introducing yourselves and telling us a bit about your role and how you've come to be sitting in the seats that you're sitting in?
Sure.
If we can start with Fleur.
Yeah, so the patients come to me first because I'm the fertility specialist. So I'm an obstetrician, gynecologist, reproductive endocrinologist and infertility specialist. And I spend all day helping women and couples have healthy families. And one of my roles is helping people not have children affected with certain genetic conditions. And so patients will come to me with various different genetic conditions, and we work them up for treatment so that we can do an IVF treatment cycle. So I run the IVF component of the treatment to help find the embryos for Sharyn to then test. And so over to you, Sharyn, in terms of your role in this process.
Thank you. So I'm a scientist, and my role in our company is to oversee all the genetic testing that we do in our laboratory for genetic diseases. So we test human embryos for identified genetic variants that are causative of a number of different genetic diseases, including cancer.
And we should say that we work at Melbourne IVF, but we are part of a very large network of clinics. under the Virtus Health umbrella, which is throughout Australia. And Sharyn receives biopsies from embryos, so a few cells from an embryo from around Australia to run the specialised testing.
That's correct,
So,
yes. We received them from Queensland Fertility Group and IVF Australia and Sydney, and also Tasmania and other parts as well.
You sound both very busy, and we're very grateful to you both for joining us. So thank you. I know that you've got some, we don't often use slides in our Facebook Friday presentations, but when I was talking with Sharyn ahead of this week, she showed me some pictures, and I thought, oh gosh, I think our audience are going to be really interested to see the images on the screen. So I'm just maybe I'll hand over to you, Sharyn, and you can share your screen and maybe take us through those slides. And I might hide my camera so that there's just the, I'll leave it up to you for the next few minutes.
Okay. All right. I'm going to.
And a few people are watching, so that's exciting. So hi to those who have said hi.
Okay. That all looks good?
Yeah, some lovely images from our laboratory. I think one of the exciting images on that screen there for me would be the Embryo Scope images, which is, you can see lots of embryos developing in the bottom left photo. And so we have 24/7 video footage of all our growing embryos. So an embryo, of course, is made from an egg and a sperm. We fertilise them in the laboratory and we put them in the incubator. And then we can watch them grow up to a point where they're suitable for what we call embryo biopsy, where at that point they're about 100 cells big, and we can see the difference between the future placenta and the future baby, so that we are taking a few cells from that future placenta.
And we have a few pictures and videos of that coming, so we can explain that more as well. So this is the first image which Fleur will describe.
This is sort of still in my realm.
Yes.
So what we need to do in order to test embryos is to make eggs and then collect them and fertilise them with sperm and then grow the embryos and test them. So we need to do an IVF cycle to achieve this. So what we do is we teach women how to inject themselves with 2 weeks of hormone. I can show you the pen we use, actually, if you can see. Oh, where are we? Yeah. So it's a tiny little needle. They use once a day for a 2-week period. And during that time frame, I'll do a couple of vaginal ultrasounds to check on the eggs growing. So each one of those circles, those black circles, is a follicle that contains a microscopic egg. And when they look ready to collect, then women will come into hospital, go to sleep for 20 minutes. I put the ultrasound inside and then the needle through the top of the vagina to collect the eggs. So you can see the vaginal probe inside, tiny little needle about the size of the tip of a pen, removes the fluid that then the scientist can identify the eggs. So it's a straightforward procedure, minimal pain generally, a little bit of period pain, people recover pretty well, go home that day. And then in the laboratory, after the partner has given a sample of sperm, we pick the best sperm and inject them into the eggs, which you can see here is we call intracytoplasmic sperm injection. So normally sperm will find their way into the egg. So you'll have 100,000 sperm trying to get into that egg, but that would contaminate the results in terms of the DNA and the testing of the embryos. So we need to make sure that we've got the DNA of one sperm into each egg. And then in the embryo scope in the incubator, we watch them growing. And when they get to a little bit beyond the stage of the, here we go, beautiful blastocyst here. So that is a day 5 embryo. It has 100 cells also, and you can see the ring of cells on the outside. and the little blob down the bottom is the future baby. So we take a few cells out of that future placenta, and then we freeze the embryos until we get the results.
So what I have here is actually a nice video showing the embryos growing in our Embryo Scope. If everybody wants to concentrate on this one here, these are eggs at the moment. And then these are images that are taken every few minutes while the embryos are growing. If you watch this, the cells have started to divide. This is about 2 days old. They continue to divide. And they start to form this shape Fleur was talking about here, where they blow up like a balloon. That's a blastocyst stage, and that's where we do the embryo biopsy. What's interesting to note here is not all of the embryos here actually make it to that stage of development. Many of them stop growing.
It's a normal thing that happens. We always start with a big egg number, so we might start with 8 to 12 eggs and end up with 3 to 4 embryos for testing. So embryo biopsy is shown in a slightly different way. So we can see which is the future baby that we need to avoid and just take the sample from the future placenta. Embryos cope quite well with this process. Very few would be affected in a detrimental way. There's been millions of babies born now through IVF, and they're healthy, and many through testing like this, and there's no long-term effects. Then the sample needs to be carefully placed into the tube here. Sharyn, did you want to talk more around that?
Yeah, so I've got a video of an embryo biopsy on the next slide. So I'll explain a bit more about that in the next slide, but basically a few cells are removed from the embryo. They're put into this tube that's actually very tiny. And what we do then is I'm not sure if everybody can see that. I can move what we then do is amplify the DNA from the cells. So when you have a genetic test from yourself and a blood sample is collected, or a cheek swab might be collected, there's thousands and thousands of cells within that sample that DNA can be removed from, and then the DNA can be interrogated or looked at to identify the information that we're trying to find. So in this case, of course, the information is whether or not a particular gene variant is present or it isn't. Now with when you take a few cells from an embryo, there's not enough DNA within the few cells, which is about 5 cells, to be able to get the information that we need. So we have to copy the DNA or amplify the DNA in order to be able to get that information. So this is the video of the embryo being biopsied. So this is this region that is going to become the baby, and that is carefully avoided during the biopsy. And a few cells are removed from this part of the embryo, which goes on to become the placenta, and they're gently removed to have as minimal impact on the embryo as possible. So there's a laser that gently removes these cells from here.
You notice the embryo collapsed, but that is the fluid inside the embryo. So that is actually part of the freezing process as well. The fluid is removed.
And these cells here will be loaded into that tube I showed on the previous slide, and then sent to the genetics lab for testing. So this, when somebody carries a cancer predisposition gene, like these ones here, which are the ones causing many neuroendocrine cancers, they follow what's called autosomal dominant inheritance. So in this example here, we've got a couple, and it's the man that is carrying a variant in one of these genes. So he has 2 of these genes, and one of them has the variant and one of them is normally functioning. And when he passes on, he'll pass on one of these genes, but only one in each sperm that he produces. And it will either be the one that contains the variant or the one that doesn't. So that means that any embryos or any children that he has have a 50% chance of inheriting that gene that can predispose for cancer. Now, just this slide just briefly explains how the genetic testing works. So as in the previous slide, we have this couple. The man here is the one who's carrying the genetic variation, and he's inherited it from his father. Now, when we do this testing, we collect DNA from the couple, so the woman and the man, and we collect DNA from a family member whose genetic status is also known. So in this case, we know that his dad also has this gene variant. So these are coloured bars here represent the gene regions of their particular gene. So in this case, the woman has 2 copies of that gene region. She doesn't have the genetic variant that contributes to the cancer. He's also got 2, and his dad has 2. Now, the blue one is the one that he has common with his dad. And as we know, he's inherited the genetic variation from his dad that causes the cancer. We know that it's the blue gene that is the one carrying the variant that causes the cancer. So when we test,
you have to do all this workup before you actually start the testing. So you take samples of DNA from these family members.
Yeah, that's true. And it just takes a few weeks for us to do that initial testing. So when we test the embryos, what we're looking for is these same gene regions. And in this example here, these 2 embryos have inherited the red gene region from their father, and therefore these embryos won't have inherited the cancer predisposition gene. And these 2 here that have inherited the blue have inherited the cancer predisposition gene. So it's important to know that when we do this genetic testing on embryos, we're not able to correct the gene variant. What we do is we look to see if it's present, and embryos that don't have it are the ones that can be transferred to the woman's uterus and used. And then Fleur can describe that process of embryo transfer.
Yeah. So it's important throughout the treatment that the couples don't have a chance of conceiving naturally, because they're generally all fertile people. So if they have sex, they must use condoms so that we don't have a natural egg fertilise. All patients are advised about that. And then after we find an embryo that's suitable for transfer, then we need to replace the embryo in the uterus at the right time in the cycle. So generally, if we've frozen the embryo 5 days after an egg collection, we transfer the embryo 5 days after ovulation. And then we wait. So it's 10 days until we get the pregnancy test from there. And the chance of pregnancy does depend on several things, but it is about a 40 to 50% chance of a pregnancy at that moment.
Yeah. So that's the end of our slideshow there, Kate.
Awesome. So thank you so much. And that was just really fascinating. I know the people watching would have found that really interesting as well. Sharyn, can I just ask you, the video that you showed me, and I found, you showed me this the other day when we were talking about it, and I was just blown away. I was so amazed by it, which was the image of taking the biopsy from the blastocyst, from the very tiny embryo. Can you tell me how you do that in real life? Because obviously there is a very tiny suctiony thing that's pulling those cells off, and a very tiny laser. Are you doing that by hand?
So the scientists are doing that. No, they've got special instruments to do that, but they are controlling them by hand. So it's a very highly trained scientist doing that under a microscope with some specialized equipment. So yeah, so they've got a little pipette holding with a bit of suction on the embryo, and then another one gently pulling the cells out, and then that laser slightly gently cutting through the cells to be able to separate the cells from the blastocyst.
Yeah,
wow.
The piece of equipment is called a micromanipulator. So it's a little bit like playing video games.
It just blows me away. And when I was talking with you this week and today, I've just been blown away by how much I've learned about that process. Can I ask you what happens? Well, firstly, you can check for genetic abnormalities that are inherited. I can't talk today, from either the mum or the dad.
Yes, it's that example is just the dad, but it works equally well with the mother.
Okay, and so you know, if you have 4 embryos and 2 of them contain that genetic fault, what do you do with the ones that have the fault?
They're not transferred.
They're not able to be used.
Okay. And so can I ask you, on average, when you're doing this sort of process, and it's probably, I'm thinking as I'm asking the question, it's probably a little bit of an impossible one to answer. So you may well tell me that it's impossible to answer. But would it be rare for someone to achieve a pregnancy on the first cycle when not only you're doing IVF, but then you're doing this screening as well? Does that, I guess what my question is does that decrease the rate of pregnancy, of healthy pregnancy, to be doing that sort of screening?
Well, generally, these are fertile people. So you're already starting with healthy sperm and eggs. However, you generally, in this example, with half the embryos are not suitable for transfer, so you're reducing the pool of embryos to work with. Because you're dealing with small numbers, the way the numbers fall can go in many different directions. So, you know, for some women, they might get eight eggs and 4 fertilized and 2 embryos, and they're both affected. And so then we've got to do another cycle. And they might get, 12 eggs and 10 fertilized and 5 for testing and 4 are suitable for transfer. When you're dealing with small numbers, it doesn't fall exactly as the odds would show. And so that makes it difficult to predict how this process will work for an individual couple, except to say that for most couples undertaking this, it works beautifully and they fall pregnant within a few transfers. So it may not happen the first time, although, you know, with the odds of, roughly 1 in 2, it certainly does happen the first time. But couples do need to be prepared for it might need to, be repeated. And sometimes that means repeating the whole IVF cycle where we're doing the 2 weeks of injections and the egg collection and making more embryos. On the other hand, there are couples that will complete their entire family from 1 egg collection. So they'll have 1 for embryo transfer, and that'll be the baby, and then there'll be another 1 or 2 for freezing for the future. That the chance of pregnancy is just as good in a few years' time, even though the woman's a bit older, because of course age has a big effect on chance of pregnancy. But if you perform IVF at the age of 35 and then you transfer the embryo at 40, they've still got the chance of pregnancy as per a 35-year-old because the embryo has been frozen in time.
And I just wanted to ask, I feel like I know the answer to this question, but people who are watching might be wondering, we're talking about screening out a genetic fault. This is obviously a genetic fault that's been passed down through the family line, because we know that cancer actually starts because of a mutation in a gene. And I know that, in neuroendocrine tumours, it's about 90% of people that it's a random mutation. It's not actually because of a familial link. So just to clarify that this highly specialised process is really only for people with an identified familial link to start with. Am I correct in?
That's correct. Yes.
Yeah.
Absolutely. Yeah.
And do you ever get people who approach your clinic who maybe haven't gone through that genetic testing process with a family cancer centre and are asking you to look at their genes and make that examination?
It's not generally the pathway that patients get to us from. If they were to go that direction, generally they would be referred to our geneticists. So we have specialised geneticists that can tease through a family history and determine which tests need to be done on that, that couple to determine if it's familial.
Yeah, they're usually referred after they've already had testing at somewhere like the Peter MacCallum Institute.
Yep.
Yeah. And in terms of what we are allowed to screen embryos for, we can only look for serious conditions. So can't screen for just anything. It has to be a serious genetically inherited condition.
Okay. So you can't request blue eyes as well as.
We can't even do that anyway. It's a bit of a fallacy. But yeah, no, we can't by law. And, it's for, a lot of the situations that we do this testing for, it's often been in a couple that have had a child with a very serious genetic disorder, might have had to watch a child succumb to an illness over a few years of life. So to be able to offer this and prevent them going through that sort of trauma is just such a great thing for them. So that would be a more common scenario in terms of the patients that we would see, I would say. Yeah, it's usually there's been some hidden gene in family where they both members of the couple carry, and they didn't know that they carried them, and then they're just unlucky that their child has had a serious genetically inherited condition, and then we can help them have a healthy child.
And I've got I remember very clearly a conversation with someone from our community who they do have a neuroendocrine cancer causing gene strongly in their family, and they went through the process of the pre-implantation screening and have had 2 healthy pregnancies, have 2 gorgeous little children now as a result of those pregnancies. And for them, the peace of mind of knowing that they've had children who don't have that genetic fault has been just wonderful, because they've seen so many people in the family go through the hardship of having that genetic fault that's meant they've had lots of cancers, lots of neuroendocrine cancers. So I'll make sure I put the link there. They actually wrote their story up for our website, so I'll make sure I put that link in the notes. Fleur, you look like you want to say something more.
I think, if in that situation, it would be a gift that you're giving your child, really, to be free of the condition that you've experienced in your family, to be able to not see your child have to go through what perhaps you've seen family members go through. Did you want to add to that, Sharyn?
Oh, I just wanted to say that actually we do a lot of this type of testing for that group of patients who do have a cancer predisposition gene. We do a lot of the BRCA1 and BRCA2, but also quite a few of these neuroendocrine tumor causing genes. It's one of our quite common reasons for referral reasons for PGD.
And I'm just wondering, and maybe we'll look back to this, but I want to make sure I remember to ask you about sort of, I guess, the counselling and support aspect of this, because having children, even under the most boring of circumstances, is a deeply emotional process. And I know from close friends who have been through IVF that's been really complex for them. But I imagine with all of these things to be considering with the pre-implantation genetic screening, that it would be even more complex. Maybe we'll talk about that now, if that's okay. Can you tell me a little bit about the sort of support processes that you have for families as they're going through the IVF process, both just the general run of the mill, where someone has approached the service to achieve a pregnancy where they haven't been able to become pregnant on their own, but also what sort of support's available for people as they kind of, I guess, consider that pre-implantation screening?
Well, there's two components of that really. There's the genetic counselling component, and then there's the psychological support component, counselling. So the genetic counsellors will see the patients actually, and they're consented for the treatment, so that not only have they seen the geneticist, but they've had a specifically trained counsellor go through the condition and what we are hoping to achieve. So we would hope that they feel fully informed about going into the treatment. As separate to that, certainly by law in Victoria, you must have counselling separate from your doctor to explain the treatment, so that you understand the concept of making embryos, not transferring embryos. What would you do with those embryos if you broke up, if something happened to you? That all must be thought about before you undertake fertility treatment. Once you're in treatment, all the IVF clinics have a counselling service because that's part of our accreditation. We must be able to provide that for our patients. And some people will need that, and some people won't. That supportive counselling process, it just depends on, sometimes it depends how easy the treatment is, and also it just depends what else is happening in their life, and perhaps where they are with relationship to the condition, and what else is happening.
Well, thank you for describing that, and I think it's really I guess it's important to highlight that it's not just a scientific process, is it? That it's a family process, and there's lots of issues to be considered and discussed and mulled over. So it's great to hear that actually there are some firm laws to require people to have some support as they make those decisions. We've talked about some very focused work that is applicable to a small segment of our neuroendocrine community, and I'm so thrilled that we've been able to examine that, because I don't believe that the information has been really out there and very easily available in that kind of easy to understand bite-sized information. So I hope it's helpful for people who are watching the video. But I also am aware that we've got, around 90% of our community, not everybody, as a lot of people have completed their families and then they discover that they've got a diagnosis of cancer. But, NETs affect people of all ages. And so it's not uncommon for me to be talking on the phone with someone who's diagnosed at an age where they might still be wanting to have a pregnancy, and they are faced with the decision about having chemotherapy, having radiotherapy, perhaps having invasive surgery that might affect their fertility. I'm wondering if we could talk about some of the options for people like that, both women and men, in terms of the egg and ovarian tissue and sperm freezing, and what can be done in that space. Is that okay for us to discuss?
Yeah. So we have an urgent fertility preservation service. So if someone was diagnosed with a cancer and needs to see a doctor urgently, then they would contact our clinic or any of the Virtus Health clinics, and that patient would be seen within 24 hours. It's a very quick process because time really matters in that situation. So that means that they see an experienced doctor. There are certain doctors within our group that have a special interest in this area because it can get quite complicated, and they will have an urgent consult. And for men, it's a sperm freeze. It's pretty straightforward. For women, usually we need to look at how much time do we have, and how comfortable is the treating doctor, for the cancer doctor, happy, how much time is safe to devote to preserving their fertility for the future once they get better from the cancer treatment. So generally we can rush through an egg freezing cycle or an embryo freezing cycle that can generally be started at any time in their their treatment cycle. So we modify what we normally do for an IVF cycle so that we can do things quickly, basically. For some women, if that time frame is of 2 weeks is too long, and they might need to consider preserving some ovarian tissue, which involves a surgical procedure to take a sample of tissue and freeze it in an expert way. One of our specialties is to a referral service to collect that tissue, and that it's frozen at the women's hospital. So there's a transport service to collect that tissue from all parts of Australia and have it frozen with the expertise at the women's hospital, which is one of our partners. And once they've recovered from their cancer treatment, then that tissue can be grafted, as we call it, back into the woman. And within a few months, the function of that ovary has been shown to commence, and babies have been born from that. It's moved from what we would have said a research or experimental treatment to an option for treatment. And sometimes both of those options are undertaken. So eggs are collected and frozen, and tissue is taken for freezing.
And so just to clarify, you mentioned a 2-week window, Fleur. So was that the amount of time that someone's treatment might be delayed in order to go, a woman to go undergo a very quick ovarian,
yes, yeah,
yep,
yes,
egg collection?
Yeah, so because that's the length of time required to grow eggs within the ovary with the 2 weeks of injections. So that, exactly.
Okay,
Right.
well, that's really useful. And there is just a question that's come through in the chat, and I wondered if we, knowing that you're in a specific clinic and there are lots of services out there in Australia land, so this may not be applicable to every person, but the question was, is this process, and it was when we were talking about the pre-implantation genetics, but actually probably let's talk about it in all contexts. So what proportion of these sorts of services are covered by Medicare? And the person's asked, if not, what sort of out-of-pocket costs are involved? So I know that we probably can't give a specific quote via internet, but if you've got any information at all about at least the proportion that's covered, that would be interesting.
The urgent fertility preservation services, the aim with that is for patients not to be paying for, not to have to think financially at the time when they're faced with these sort of decisions. So finances shouldn't come into it. So that's the general concept with that. With an IVF cycle to test for a genetic condition, Medicare does subsidise IVF. So just to give you a bit of a rough guide, patients are out of pocket about $5,000 to $7,000 for an IVF cycle. It actually costs $10,000, but Medicare pays for half. And then that extra component is the workup of the test, so that we can make sure the test is running correctly for the embryos. There is a Medicare rebate that the government announced in the budget that we're expecting to commence, but at the end of the year. So they haven't released exactly what that figure would be, but it might be a couple of thousand cheaper when that comes in.
Oh, that'll be interesting to hear, and so it's, and I imagine that it's probably very individual, and it'll obviously depend on how many cycles someone's requiring and all of that sort of thing. But
I think that the wonderful thing about that government decision is that it acknowledges the importance of this testing that we're doing, that for serious genetic conditions, it's important for couples to have the option of not passing that condition on to their children. So I think it's great acknowledgement for that. Could we mention McKenzies Mission, Sharyn?
We can, but McKenzies is not obviously the different genetic conditions.
I guess it's just an acknowledgement from the government of the importance of
testing. Yes. Yeah.
So
okay. So yeah. Oh, okay. Well, so McKenzies Mission is a federally funded research project that's named after a little girl called Mackenzie who died when she was a few months old of a really terrible genetic condition called spinal muscular atrophy. The way that that's inherited is very different to the cancer predisposition genes. That's where the couple each are carriers for this condition and they don't have any symptoms themselves. So they are perfectly healthy. And then they come together and both of the genes with the genetic variant in it are inherited from the parent into the baby, and their baby is left with two genes that don't function at all, and then the baby has quite a serious illness. And cystic fibrosis is another common disease that's inherited in the same way. And so this project, the federal government decided to provide money for, and it's a pilot study to see the value in having couples who wish to start a family and having them have genetic testing prior to starting a family to see if, as a couple, they might have an increased risk of having a child with a genetic disorder. And then if the couple is at high risk, then the government was paying for the IVF and the genetic testing of their embryos as part of that research study. So the federal government was definitely acknowledging the importance to couples and planning for families and being able to prevent having a child with a genetic disease. So, and we're part of McKenzies Mission, and that we are doing most of the genetic testing on the embryos as part of that big federal research pilot. Yeah.
Oh, thank you, Sharyn. That's really interesting to hear, just from a being human point of view, that work's being done. But I think also for our patients with those inherited mutations, obviously that's a different situation to McKenzies Mission, but it really does highlight the fact that there's government acknowledgement of the importance of this process for people broadly, yeah, with conditions that you know, genetic testing would help. So that's really really fantastic to hear about. I'm just going to give a final drinks call or a final questions call. It is Friday after all. Actually, Facebook told me not only is it Reconciliation Week, but it's National Cheese Day apparently, or International Cheese Day. So that's in the agenda for tonight. But just if anyone's got any last minute questions, and this would be a perfect time to type them into the box on the chat as we speak. But just Sharyn and Fleur, I'm so very grateful to you both for spending your time, your valuable time today talking with us about this really important topic. I know it's quite niche for our patient group, and a lot of people with neuroendocrine cancers, this is, I guess, less relevant to your day-to-day life. But for the people where this is a concern right now, and fantastic that we're able to record this for further down the track too, for people we know that they really want to have access to this information when they need it. And so we're very grateful to you both for sharing your expertise and you know, with us today. So thank you so much. Is there any final comments that you would like to make?
Just thank you very much, Kate, and just to everyone watching, good luck with everything, all the best with your journey.
Yeah, and likewise, and I think it's important to mention that we really enjoy this work because we really feel we're providing an important service, and I know I've been honoured to be involved in this work all the years that I've been doing it. I know everyone else like Fleur feels the same way. It's amazing to be able to help people have healthy family.
I can't imagine how rewarding it would be to see people, you know, see the results of that work. So yeah. Look, thank you both for joining me. I'm going to let you, there's no further questions, Your Honours, so I'll let you press your little red buttons to gracefully exit the meeting, and thank you once again. And I've just got a little bit of news and updates for our neuroendocrine cancer community as I do every week. So
thank you, Kate.
Bye.
Bye.
Thank you. So look, I'm not going to take very much time today, but really there's very important updates to announce. The first one is that next week we are actually, because Sydney are not in lockdown, we're very excited that there is actually going to be a face-to-face opportunity. There's a Q&A session at the Counselling Institute which is on the same grounds as the Royal North Shore Hospital next Wednesday evening. And that's being run by Sydney Vital with net experts, and there's actually going to be a patient gathering an informal patient gathering before that meeting starts. So I'll make sure there's a link to all of the details about that in our notes. It's only just been announced because obviously we were waiting till the 11th hour to press the go button, because everybody's watching the COVID statistics very carefully. So obviously, if you register for that, we will be in touch with you. We'll have your details so we can be in touch with you if anything changes. But we're crossing our fingers that we'll be able to go ahead with that event, and it's really exciting to be able to announce that. The other things just to say is that we've got a face-to-face support group meeting in person in Brisbane next week. So if you're in the Brisbane area and you'll be around next Tuesday the 8th and you're not part of that support group email address and you don't get the details and you want to be, please let me know. And my contact details will be in the notes. We want to make sure as many people who want to come to those groups can make it along as possible. So just an important proviso with people who are coming back to these face-to-face events. We're not policing this, we can't police this, but we're strongly encouraging people to come back when they've had their COVID vaccine, at least their first vaccine. We've got Brisbane and we've got a Sydney face-to-face gathering. Next week is also supposed to be our Melbourne support group, and I nearly cried when Melbourne went into lockdown because I was so looking forward to seeing all of our Melbourne support group members again, because we haven't met in person for a long time, and sadly we are going to be Zooming in June. So that's next Tuesday evening. I've sent the details out via email today, so if you're in that group, have a look in your inbox or in your spam folder if it's landed there. There's details of how to log in to Zoom. Pajamas are optional. Have a plate of something yummy and a glass or a mug of something else yummy, and we'll look forward to Zooming together if you're in the Melbourne region. And the other thing I just wanted to say is that next week's Facebook Friday, we've had guest experts every week for quite a few weeks. We've been really spoiled, but next week you get me to yourself. So this is a choose your own adventure topic week. I did have dealing with a stoma sort of penciled in to that slot, but there may be other things that you really want me to talk about. You might want me to do another back to basics on another thing that you feel like you wish you'd known about when you were diagnosed, or you're newly diagnosed and you're struggling with this thing that everybody seems to know what it is. Let me know in the comments. I will be very interested to hear your suggestions and your ideas and your thoughts. If it's a silent space, then we'll talk about stomas next week. So I'm really looking forward to that. So I'm going to leave it there, and thanks everybody for logging in today. I know it has been a real niche topic, and so thanks for hanging in with me. But I'm super excited that this video will be available as an ongoing resource for people, so that they can access this information as they need it, when they need it. So thanks everybody, and I will look forward to seeing you next week.